is Guardian Radio, your station for up-to-the-minute news and intelligent, interactive, and engaging conversations. 96.9 FM. The views and opinions of the hosts and guests are their own and do not necessarily reflect the views of the management and staff of Guardian Radio.
With early detection comes early prevention. Put lead in your pencil, make you feel like a champion. Rise up again, let nothing keep you down. To live your best, hear the urologist speak. Oh yeah. Think you're losing grip of your man, don't give up on hope. Don't be ashamed, it's time to take control. Get some help from the urologist. You will find he'll help you solve your problems on 96.9. I telling you, with early detection comes early prevention. Put lead in your pencil, make you feel like a champion.
Good evening, Bahamas. This is the Urologist Speaks with Bahamian Urologist, Dr. Greggory Pinto, and my co-host, Dr. Wesley Francis, who is a Bahamian surgical oncologist and general surgeon. We have as our guest of honor, in recognition of Colorectal Cancer Awareness Month. It's April 1st, but we're talking about the month of March, where unfortunately, as the outgoing president of the MAB, Dr. Jim Earl was not available last week because of the MAB conference. So we're talking about colorectal cancer awareness and colorectal health. We have the pleasure, of course, of having our cancer surgical expert in the form of Dr. Wesley Francis and the well-loved and beloved Bahamian gastroenterologist, Dr. Gemma Roll. Thank you for being here, Dr. Wesley Francis, again.
It's always a pleasure.
And Dr. Gemma Roll, thank you again. As always, you've been here many times.
Thank you so much for having me.
The wealth of the nation is the health of the nation, and education is key. We're trying to uplift the nation in every way possible. And we're going to do it one person at a time. So it's a little bit of a inspirational talk from me. Nothing in life is worth anything unless you have to take risks and make sacrifice. Don't be afraid to take those chances and dream big. So wake up every single day thinking about, how can I change my life for the better? How can I improve the life of my family? How can I improve the life of my community and the Bahamas as a whole? But you need to make the decisions that you will not be ordinary, that you will be great, that you can have an everlasting potential. And as long as you have a heartbeat, as long as you have air in your lungs, you have the opportunity to change this world, this Bahamas, change your life for the better. So through all the chaos and all the pain, God is building a warrior in you that can overcome the most trying of circumstances. So never give up, and let's never give up on the Bahamas. So for Colorectal Cancer Awareness Month, first I want to remark that it's a very disturbing trend, particularly in the last 5 years, that there is an uptake worldwide in terms of the number of persons less than 50 who are being diagnosed with colon cancer. And unfortunately, many of them are being diagnosed as an advanced stage. Firstly, Dr. Gemmerol, why do you think we're having an upstage in persons younger than 50 years old being diagnosed with colon cancer, not just in the Bahamas, but worldwide?
For one, well, recall that we decreased the screening age to 45, right? So we're picking up colon cancers earlier than we would, perhaps at a stage that is curable. So that's one. Why are we developing colon cancer at an earlier age? That's multifactorial. Our genetics are what they are. But diet, there's always room for improvement. We're in the age of fast food. So foods that are high in saturated fats, lots of carbohydrates, low in fiber. So that's another. And then I think that shifts in the microbiome, having these super bugs as we are exposed more to antibiotics, and we have changes in our flora that can contribute to dysregulation, right, in the gut to protect us from developing tumors.
Well, let's not take for granted that everybody listening understands what exactly cancer is. Obviously, it's a terrible ordeal for anyone to go through, and it can be life-threatening. But cancer is both a genetic and a metabolic disease. So what drives cancer? Cancer is essentially unregulated cell growth or dysregulated cell growth. So cells that grow without responding to normal cell growth signaling. So there's a strong immune response in regards to cancer. And cancer is strongly influenced by the immune system, the metabolic health of the individual, and the ability of the individual to acquire mutations and repair them. So unfortunately, we do have a lot of mutations in our relatively small genetic pool of 400,000 individuals. But if there's one take-home message today from our messaging regarding to colorectal cancer, I would like it to be that nobody needs to be dying of colorectal cancer. Colorectal cancer is a completely preventable disease, a completely preventable cancer, where colonoscopies, which we'll speak about in more detail in a moment, are both therapeutic and diagnostic. So before you develop a cancer, you're going to develop pre-malignant polyps that reach a certain size and then develop over a period of maybe 6 years, 8 years, 10 years into a cancer. If we can find those polyps before they develop into cancer, we can prevent colon cancer. Can you speak a little bit more about that, Dr. Francis? Because I know you live with a lot of heartache every single week, seeing persons of all ages being diagnosed with stage 4, stage 3 colon cancer, many of them with their whole life ahead of them, and it was completely preventable. Please, let's hammer home that message.
No, absolutely. It takes time for a polyp, which is a growth within the colon, to go on to develop into a cancer. It has to mature, and it takes time. Sometimes people say up to about 10 years. And so you have a lead time before which that can be, if that is removed, you can totally prevent. I always say, when you think about breast cancer is not preventable. And so the efforts, the public health efforts out there is to early detect. But with colon cancer,
but I'll
it's
temper
different.
that. Breast cancer with, as we've spoken many times, modifiable risk factors, we can significantly reduce an individual's risk.
Reduces risk, but
and
we can't
risk
prevent
within.
risk reduction strategies. But I mean, the whole idea is that
Prevention.
the screening is not to prevent it. It's really to early detect it.
Yeah,
But
so
with colon cancer, it's to prevent. And that's
Yes.
the message that we have to hammer home, right? I mean, if you get a colonoscopy and you find a polyp, it can be removed at that time, and then you don't go on to develop colon cancer. And so that's why screening is important. But I'd like to add, though, because you opened up the program talking about statistics, increasing numbers of colon cancers worldwide, and especially colon cancers in early age. But I just wanted to share, we have a cancer registry, and we started to record data from the private and public sector around 2018. And what we've been seeing is a trend actually in the last 3 years in a reduction in incidence of colon cancer. I can't really tell you why yet. I believe that the data is not that mature so that we can really say why is that real. But if we look at our own personal data, it's been going down. In fact, it has gone down by half. In 2021, it was 22.4, and this is incidence rate per 100,000. And in 2022, it was 15.6, and in 2023, it's 12.5, which you would see a smooth reduction, which is good. I mean, we'd like to see that. We hope and believe that is true. But you got to look at the data,
Yeah.
and that's what the data says.
May I interject? I'd like to.
Let's talk about it.
So 10 years prior to that is when we saw an influx of gastroenterologists.
Yeah.
Okay. Shout out to the forefather of gastroenterology here in the Bahamas, one of them, Dr. Harold Munnings. After
and
him,
Nemhard before him.
well, Dr. Nemhard, rest
Yeah.
in peace.
Yes.
But, for many years it was a one-man band, right? And then along with Dr. Floyd Carter, who pretty much came up under him. And then thankful for the surgeons that would have done lion's share of the screening as well. Dr. Francis, you included.
Yeah.
But then there was an influx of gastroenterologists. So we have about 5 of us now here in country. And that happened a bit over 10 years ago. And I'd like to postulate that that is perhaps why we're seeing, based on the statistics that have been registered, a decrease in colon cancer rates because we're doing more colonoscopies. We're doing more screening.
More, which is
we
a
are
prevention.
doing more promotions, more awareness. We capitalize on this month of March to raise awareness in colon cancer and prevention.
Absolutely.
Yeah.
Well, I'd like to mention my brother is a gastroenterologist who's currently working in New Jersey, and I've always encouraged him to come home. Maybe one day you will join your ranks. But let's talk about what is the purpose of cancer screening. So essentially we detect persons with a disease or risk of developing a disease, but have not developed signs or symptoms. So i.e. healthy people. So this allows for early detection of cancer that improves the chances of cure. So obviously every cancer, colorectal cancer is no different. The earlier that you can detect it, the greater chance or high probability that you're going to have a cure without any chance of later recurrence. So screening in itself doesn't provide a diagnosis. You need to diagnose a cancer with radiological evidence and, in most cases, a tissue pathological diagnosis. So screening of cancer, there are only really 5 recommended cancer screen. One is a colonoscopy for colorectal cancer. One is a PSA, prostate-specific antigen blood test for prostate cancer. For cervical cancer, there are pap smears where we can also detect DNA for HPV in our blood. And then obviously there's a mammogram for breast cancer. And then we look at LDCT, scans for lung cancer. So therefore, the vast majority of cancers don't actually have a screening tool. That's where we're looking at the future of screening. And Dr. Francis and I have discussed it many times. And that's looking for cancer-specific signals in your blood. So it's able to do that by detecting cell-free DNA that is shed by a tumor very, very early on. So we can also detect where in the body that cancer signal is coming from. So a possible signal from, for example, there's a Greggory test, which is FDA approved. You need a further a test to confirm diagnosis, but essentially you can pick up a potential person who hasn't had any signs or symptoms of, for example, colon cancer, and may not have any signs or symptoms of colon cancer for 5, 6, 7, 8 years. So we can stratify somebody into being specifically high risk and really screen them very closely. Can you talk a little bit about the onset of these tests, Dr. Francis?
Yeah, so, I mean, I think medicine is evolving, and we're moving into precision medicine and genomics and understanding the body and understanding that, these cells, before the patients would become symptomatic, the DNA gets shed into the bloodstream, and this is called cell-free DNA. And if you're able to detect that, then certainly it gives you a lead time. It's not a confirmatory test; it's a screening test, and so it's still in its infancy. But certainly there has been a test that has been FDA approved that you mentioned, the Greggory. And so it's also the concept of liquid biopsies that sometimes there's no tissue to get, but you can get the same cell-free DNA. And with the current tools and being able to to detect these in the blood, then you're able to one screen, and also, I mean, another application of these tests is to monitor. So
For recurrence
for
as well.
recurrence,
Yes.
it's called molecular residual disease. So, for example, let's say you have colon cancer, and we treat you, and we use the test to see if there's no longer any cell-free DNA within your system, and so that would be a molecular cure essentially. And if we monitor you over time, and we start to pick up more cells, then we know that there's a chance then that you can have recurrence, and you can pick up these recurrences even before seen on imaging. And again, gives you that lead time. And information is always important, right? If you can get a lead time before persons are symptomatic, then you can then apply treatments earlier. And so that's where the technology is heading. I mean, it's very interesting, and it's revolutionizing the whole precision medicine, and I think that's where the world is headed.
In furtherance to precision medicine and cancer treatment, surveillance, we also do genetic testing on the actual tissue biopsies or on the surgical pathological specimen, which can allow us to stratify patients into which patients are likely to have a recurrence.
Right.
Is someone going to have a 5% recurrence risk in the next 20 years versus someone who's going to have a 66%? So how you would surveil that person post quote-unquote cure is going to be completely different.
Yeah,
because every cancer is different.
Right, everyone is different.
So not one cancer is the same, and that's what a lot of people
right.
don't understand.
It's all
So they'll say,
different.
why does my sister have a certain breast cancer and treated a certain way, and my grand aunt was treated completely different, because they're completely different entities. The same for colon cancer and other cancers
I mean,
as well.
we use that a lot in breast as an oncotype test. Postmenopausal women, they can get hormonal therapy if the oncotype test shows that their recurrence score is low, and they could totally avoid chemotherapy. And this is data-driven, data-proven, because not everybody, the behavior is different. And that's what we're realizing. And so the term that we use is called biology. The same thing applies in colon cancer. I mean,
And then you mentioned chemotherapy. If you are found to have a small lesion that you are able to excise and with a resection of your colon, and then you do the anastomosis, putting the colon together. Do these people on average require chemotherapy? Because everybody dreads chemotherapy.
Right. So with colon cancer, it's based on stage, right? Classically, if you're stage 3, which is where the tumor would have spread from the colon to the lymph nodes, then that's a classic indication for chemotherapy. But again, now we are looking at people who are stage 2, who may not have lymph nodes involved and may still be high risk. And this is where the cell-free DNA, we call it ctDNA, can be used. If there's molecular evidence of tumor still present in your blood, then that makes you high risk. And then even though your lymph nodes are negative, you should still get, because it then reduces your risk and save your life. So this is how oncology is really developing.
And
precision
precision medicine that we're speaking about is available readily in the Bahamas, and we use it all the time.
It's
We're
available.
using Gallery here.
Not Gallery. Well, Gallery is a screening test, but we use ctDNA.
I send
Where-
patients for a Gallery. I take blood and send it, but it's hopefully in the next decade is going to be widely available. But Dr. Gemma Roll, you spoke about risk factors for colon cancer. When we look at our culture, we look at our body habitus, our sedentary lifestyle, our diet, everything that we do essentially is a check mark risk for colon cancer. And then what a lot of persons are not going to like to hear, male and female of all ages, alcohol consumption is a high risk factor for colon cancer. In fact, some studies have shown it can, even moderate alcohol intake can increase your risk of colon cancer 1.2 to 1.5 fold, which is considerable. And then when we look at different parts of the colon and the rectum, for alcohol, one study I read increases a 20%, 26% increased risk for distal colon cancer, 17% increased risk for rectal cancer, and 29% generally for unspecified colon cancer. So we look at body mass index, we look at lower fiber intake, we look at lower folate intake. How can we face this overwhelming obstacle of persons who do not want to change what is essentially the Bahamian culture?
Wow. That's a loaded question. That's the $1 million question.
How do we inspire? I believe it starts from the young. I think if we can have healthy lunches in our schools, if we can we can institute exercise and after-school activities or promote exercise. Even from the age of 6 years old, we can have a future generation who are going to be a lot healthier, going to have a lot less in terms of cancer risk. We drive everywhere. We need to encourage people to find a healthy space where they can safely exercise, whether it's jog, cycle, etc. I think the government or even private individuals need to provide that for persons. You see on a Sunday 20 persons cycling, and all of them at risk because the way people drive in this country. But we need to eat right. We need to exercise, and we even talk about. Can you speak a little bit the way even that we cook our meats can put us at risk in terms of what meat we have. Whereas bacon every day is going to put you in your grave.
Well, for one, we can promote perhaps agriculture, right? We can grow what we eat. We can promote that in the schools. The snack trucks and the convenience of the chips in a bag and the cookies and whatnot. They're convenient. They are not costly. The cost of healthy foods in the grocery store may be prohibitive, right? There has been VAT reductions, correct? Today, right? We've had VAT reductions
Today?
on, April 1st. Isn't it April 1st?
Oh, I didn't know that.
It was for today, right? Yeah,
Okay.
that we have VAT reduction on non-prepared foods. Is that what it is? So produce would be a part of that, correct?
Good.
So that's one incentive or initiative to perhaps get a healthier lifestyle. But again, promotion of agriculture. Let's have a greenhouse in all schools and grow the produce.
What do you think is one of the most common misconceptions that you hear as a gastroenterologist in regards to colon cancer?
That women can't get colon cancer. That is mind-boggling to me. But, there have been women, more than I can count, more than I'd like to count, that would present not knowing that colon cancer screening was meant for them.
So we have the female and male statistics over the last year. And I mean, it's just neck and neck, almost 1-to-1.
Yeah.
There's no...
It's pretty standard.
There's not more males than females. It's pretty much even ratios.
And then
From 2018 to 2023, 2023, the males were a little more, but certainly, the data's there.
you
Yeah.
did briefly mention something that is a relatively new concept in the last couple decades in regards to how science has been looking at general health, immunity, and gut microbiome, and the risk for not just colorectal cancer, but all cancers. What's the importance? Exactly, what is a gut microbiome? I mean, it composes gut bacteria, viruses, fungi. What exactly is the importance of a gut microbiome in regards to our colon and rectal health?
So the gut has along its track several hundreds of thousands of different microbes in the gut that help us to digest food, help us to reduce inflammation, help us to get rid of bad bacteria or contaminated foods. And the gut is the largest part of the immune system, right, in it. And it is our immune system that keeps.
So basically, the gut microbiome has like three main functions. It's structural, protective, and metabolic, and it's important in the nutrient and mineral absorption. But there are a lot of things that we can do to negatively impact our gut microbiome, including antibiotics. Where that reminds me, we want to eventually have on our pediatrician in forms of your wife, Maria Francis, because it starts, and we always talk about how we're going to change our unhealthy Bahamas. It starts from the young. We shouldn't be giving children antibiotics. Every time you have a cold or a stuffy nose or a sore throat, you're giving antibiotics. And for the vast majority of cases, it's a viral illness where antibiotics have no role whatsoever. The amount of multi-drug resistant bacteria, even in urology, seeing in urinary tract infection, is scary. We're running out of antibiotics that are useful. And that trend is going to get worse and worse unless we change the way that we give antibiotics. You shouldn't be borrowing your cousin or your sister's antibiotic or your neighbor's antibiotic just because you have a sore throat. You have to have a reason for it, and it has to be the correct antibiotic as well.
But if you must take antibiotics, you can take probiotics.
Yes.
Okay, the hand that writes the prescription for antibiotics should write for a probiotic. Matter of fact, there's no downside to taking probiotics, just preventative, just for your own health.
And then even in terms of precision medicine and surveillance, a lot of research is underway, even in the last decade, in regards to the gut microbiome and its use in detecting colorectal cancer. The future hopefully will be that certain biomarkers, such as certain bacteria in the gut, can be used to identify people who are actually at high risk of colorectal cancer.
I think it was a strain of E. coli. Within the last couple of years, they found that persons that were diagnosed with colon cancer, and they studied their microbiome. It was linked by this E. coli strain. So there is a lot of work being done with that, but that's one of them.
But the most important thing is, obviously, we want to screen before you have symptoms, but recognizing early symptoms. And there are too many persons, Dr. Wesley Francis, everything is gas.
Yeah.
Everything is gas. My belly's bloated. I'm constipated for a week. There's certain persons that believe enema is the solution to all their problems. They'll have an enema every few days for the rest of their life, basically developing a lazy rectum.
I mean, your colon tends to function. I mean, the normal healthy colon is usually functions in a way that, I mean, everyone is different, but it's pretty standard. If you go every day, you're probably going to go every day. If you go every other day, there's some people go once or twice a week, but that becomes normal for you. That's your body. And if you see a change in that, then that's considered a change in bowel habits. And if you're having all this abdominal pain and what we call in gas, distension, those can be early signs of what we think is obstruction, really. And certainly you should.
Let's talk about blood in your stool or black tarry stool.
Blood in the stool.
Never assume it's hemorrhoids.
Yeah, hemorrhoids should never be the first diagnosis. It should be the diagnosis of exclusion, basically after you've ruled out everything.
I've heard it all, where persons had blood in their stool almost every day, became anemic, diagnosed himself on Google, or ChatGPT with iron deficiency anemia, started taking iron, which made their stools black, and then when it was Melina's stool from an upper GI bleed or a curl.
I think people, it's just awareness, right? And health literacy, it's important. You got to read. You have to know your own body.
Well,
know what's
I think
normal and
Dr.
I think that's
Gemma Roll has said in the past, and I'll let her emphasize, you got to look before you flush.
Absolutely.
And if you see, what should you be disturbed what you see before you flush? Obviously, blood,
Yeah.
black, tarry stools. Is there
And when
anything
you
else?
wipe, look at the tissue paper that you've wiped.
Or
your
we'll
butt
also
with.
look at the consistency of your stool. If you're having pebble stools,
Thin stools.
that's also, or thin scalable stools, there may be a level of obstruction within your colon
But
as well.
what's important is to notice the change.
Or diarrhea or
Right.
loose stool.
And that's why you should look every time, because when you notice the change, that's the early sign. And because when you have a normal colon, your colon functions normally. I mean, these gastroenterologists have these stool charts in their office,
Bristol stool
the
scale.
Bristol stool charts, and each one of those means something, right? There's a whole spectrum of that.
So what do you think about this, Dr. Jim Roll? If you're concerned, do you take a photo on your phone and bring it to you?
Yes, I love that.
Okay.
Picture's worth 1,000 words.
Yes.
Yeah, definitely. We look at poop pictures every day.
So the most important thing is, no matter what, you shouldn't be afraid to discuss anything with either your general practitioner, your internist, your family medicine practitioner, or your gastroenterologist or urologist, whoever. They are there to help you. They've heard it all. They've seen it all. Nothing is going to faze them. So there are going to be persons who are going to be afraid to even tell you, Dr. Gemarol, that they have pebble stool or that they have blood and they haven't passed stool for 10 days. And
Right.
they need to open up because that can save their life.
Correct.
And there should be no secrecy between your physician and your patient. If you don't have that relationship, then not every personality is going to mesh. Then go and find another gastroenterologist. Go find another urologist. Go find another surgeon to see. All we want to do as physician is see you get better and live as long as possible in the best quality of life. If that's not with us as your physician, I'm always happy to give persons second referrals, and I always accept second referrals from other persons. So we're here as a community trying to serve the community. There's no selfishness. There's no ego between us. I call you all the time, Gemarol, for referrals and advice. I do the same with Wesley Francis, vice versa. I call other specialties. So we're all a family trying to save the family of the community in the Bahamas as a whole. Unfortunately, some persons are dealt a very unfair hand. We talk about colon cancer being preventable, but there are certain diseases, certain syndromes, such as Lynch syndrome, which is hereditary non-polyposis colorectal cancer, HNPCC. There's FAP, which is familial adenomatous polyposis. There's Gardner syndrome. There's Turcot syndrome. And if you have these diseases, your chances of getting colon cancer are exceedingly high. Exceedingly high.
So a lot of people may not, be familiar with these terms, FAP, HNPCC, Gardner's, and Turgos. But you got to know your family, and you should know, if you have 2 or 3 relatives in your family diagnosed with colon cancer, particularly at an early age, you have to start to think maybe there's something going on. And I think that's how you start there. And then the investigative physician would then delve further into that and then recognize that there may be a possible genetic link, because the individuals who have genetic predispositions are outside of the screening risk or screening age. The normal screening age now is 45, but you have these people who have genetic predisposition coming in at age 30s, in their 20s, and some are symptomatic, and they're symptomatic, and but you have to have the index of suspicion first, But then, as an individual, though, if you know and you realize that your family who were diagnosed with colon cancer on in their life, then you must think, you guys, you share genes. And so it may be that you're also at risk and you should get it checked out.
And BRCA gene 1 and BRCA gene 2 mutations also can put you at risk of colorectal cancer. So can Crohn's disease and ulcerative
inflammatory
colitis.
bowel disease,
Yes.
definitely. But again, if you have inflammatory bowel disease, you know that there's a problem, right? Because it's long-standing inflammatory bowel disease. It doesn't happen overnight.
Well,
These things don't happen overnight.
You
right?
mentioned you have family members. 3 of them might have had colon cancer at a young age. And that, as a young child, a teenager, you grew up seeing your aunt, your father, your older sister die of colon cancer. That creates such fear in you that a lot of times you have such a negative outlook on life that your life is over before it starts. You don't really live your life with happiness or anything else. You think you're going to die young. But medicine, surgery, screening is going by leaps and bounds. We have precision medicine. We have liquid biopsies. We are able to do genetic testing where not everybody even needs chemotherapy that used to have chemotherapy. We have immunotherapy as well that is a miracle a treatment as well that can melt away even metastatic disease. But some people, let's say they have FAP, familial adenomatous polyposis, and 70-80% chance of getting colon cancer. Speak a little bit before we get back to Gemma Roll about prophylactic total colectomies and what is the quality of life after that.
So we have certain families who carry the gene, and it's called the APC gene. And this predisposes them to developing colon cancer at an early age. They develop polyps even in, as early as 10 years old. I think I've seen kids with polyps who are in that family. But again, these people know who they are. And so when these kids are at, even though, and again, as we say, polyps take time to develop into cancer, even the FAP ones. And so if we can remove the entire colon before it develops into cancer, that's a prevention. And we do that, and we remove the entire colon, and we basically connect the small intestine to the anal canal. And what happens is over time, the body just adapts. And so that small intestine, which functioned in a different way before, then begins to function as a colon. And so these people can go on to live normal lives. Interestingly, I just met a patient who, came to see me who was having a baby. I don't see pregnant women, but it's interesting enough that, she had a total colectomy, which, prevented her from getting colon cancer. And the reason why, because many people in her family actually had died from colon cancer. And then they recognized in that family that they had this APC gene mutation. And so she had it done when she was 18. So patients have to be able to be at the age of consent. And so usually around age 18, they can consent. And then you remove the colon. And this girl was in her 30s. And she's living life. She, having her second child. But you see that one event, that one decision to remove a colon has led and changed her destiny, because her destiny was to develop basically colon cancer and die, like many of her other family members who had succumbed to it. But because of that decision, that basically changed the trajectory of her life. And now she's doing well. And we have a number of stories like that. And I know a lot of families in the Bahamas that we've removed the entire colon for these patients, and they're doing well.
Let's just change the topic a little bit of doom and gloom with this colorectal cancer talk. It's all important,
Well, it's
but
not-
let's
it's
also
still-
talk
People
about.
need to understand and know, right?
I agree.
think,
I agree.
yeah.
It's imperative. It's life saving and everything.
It is
else.
life-saving.
But we're talking about things that may predispose you to colon cancer later in life, and also disorders, gastroenterology disorders that affect the quality of a large population of percentage of our population. And let's talk about GERD. Let's talk about
that's
persons who
crazy.
pop Nexium and omeprazole like it's candy for year after year. And if they realize that, and there are a certain percentage of them that have that H. pylori overgrowth, and if we can give them I think 3 different types of antibiotics over 10 days, 2 weeks, you can eradicate H. pylori, and you can basically get you off the proton pump inhibitors. Speak a little bit about H. pylori overgrowth, please, Dr. Gemma Rule.
Oh boy, H. pylori is a very commonly found bacteria in the stomach here in the Bahamas and other developing countries. Okay, there was a study that was done maybe about 15 years ago by one of our colleagues that looked at the rate of finding H. pylori in patients that were having upper endoscopies, and it was over 50%. H. pylori is found in, I don't know the exact number, but patients with gastric cancer, as it is a risk factor.
Carcinogen.
It's a carcinogen that causes stomach cancer. It causes all the things that we complain about because of our poor eating habits, right? When you have indigestion, you may have bloating, you may have what we call gas. You may burp a lot. You may pass gas from below. You may have a bit of nausea. You may even have a change in your bowel habits, and could be attributed to H. pylori. It's a funny kind of bacteria because the stomach, the purpose of the stomach is to have acid. Acid will kill bacteria, but this bacteria gets to live in the stomach and wreak its havoc. When you're tested for H. pylori, and the best test would be a breath test or a stool test. If there's an indication to do an endoscopy, you should have an endoscopy where a camera goes into the stomach and finds it. But those are the best tests. If you are positive for it, you get treated for it. And then, more importantly, after you're treated for it, you should test that it is eradicated. Okay, you must confirm that you've gotten rid of it, because you can get treated and still have it, and then you still have that risk, right? And the treatment is, depending on which regimen is chosen, 2 antibiotics, or it may be 3, but 2 antibiotics and an acid-reducing medication like the Nexium, the Alocid, pantoprazole, etc. And you have to take that for 14 days. 14 days. So if a doctor tells you that you have bacteria in your stomach and they give you a prescription for 7 days or 10 days, it's not enough. And if it's only 1 antibiotic and maybe an antacid, it's not enough. You need at least 2 antibiotics for 2 weeks. And you must confirm that you got rid of it.
Probiotic with it.
Well, definitely, because why? The hand that writes the antibiotic writes for the probiotic.
that.
And so for women as well that need this antibiotic, I always ask, do you get yeast infections?
yeah.
So the prescription for H. pylori treatment is very long. In fact, I've lengthened my prescription pads because I write a prescription for H. pylori almost every single day, multiple times. Wow. We have a lot of it. In fact, my good colleagues over there at the Cleveland Clinic that we like to jump over the water and go to, they don't see it as much as we do. In fact, I have been told that the H. pylori they see at the Cleveland Clinic in Western Florida comes from the Bahamas. But you know what? Who's the expert in treating that? Our Bahamian gastroenterologists, right? And our Bahamian physicians, because we see it all the time. So we have more experience in treating H. pylori.
So can you speak to the thousands of Bahamians of all ages and both genders who take proton pump inhibitors for years and years with no end in sight?
You know, So, first of all, I would assume that you've already had your investigation. It's determined that
Well,
you have.
very few of them have.
Yeah. So long-standing reflux can cause or put Barrett's esophagus. It's not necessarily in our demographic, but I have seen a handful of patients that have Barrett's esophagus, which is a pre-malignant condition of esophageal cancer. So reflux, where acid goes into the esophagus, is not normal. It shouldn't happen, and it puts you at risk. So taking something like Nexium all the time and you're still refluxing, you should probably get investigated for that. What's the downside of taking acid-reducing medication? You have decreased absorption of crucial vitamins and minerals. It can disrupt your gut microbiome, as we've discussed earlier. For those who are at risk of osteoporosis, having a family history or the like, for osteoporosis, you're at risk of developing that even more with chronic PPI use or antacid use, such as Nexium.
And then I'm going to also introduce a concept that very few persons understand, but can cause a lot of these reflux symptoms. And I'm going to ask you, Dr. Wesley Francis, can you describe and explain to the public what a hiatal hernia is and what are the management options for hiatal hernia, along with the symptoms of a hiatal hernia?
That's interesting, right? So the body has different cavities. And so you have the thoracic cavity, that's where your lungs are. And then you have the abdominal cavity. And so the esophagus, the majority of the esophagus is in your thoracic cavity, and then the lower part of it.
And what is the esophagus?
The esophagus is basically your food tube. When you eat, you swallow, it goes into your esophagus, and then it enters into the stomach. And food is propelled downwards, and it's not supposed to come back up. And there's a well-oiled mechanism, a well-thought-of mechanism that keeps food from going back into the esophagus, propels it down into the stomach. And even if you were to go turn upside down, this mechanism should keep food within your stomach. And that's the diaphragm itself. And the diaphragm has what is known as a hiatus or an area, because the esophagus has to move from the thorax into the abdomen. That's the hiatus. And there's that mechanism that maintains that pressure there and prevents food from going up. So when you have some disruption of that mechanism, then your food is then able, or acid, or any contents within the stomach is able to go into the esophagus. And that is what gives you the heartburn. So one of the most common cause of one of the symptoms of a hiatal hernia and all of that is the heartburn. And what happened is that the mechanism or the esophagus then goes up entirely into the chest. And oftentimes, if it's more severe, the entire stomach can go up into the chest, the spleen can go up into the chest, and the colon can go up in the chest. And these are what we call hiatal hernias.
And how common are they?
I would say they're not that common, but
the
I think the majority of people
symptomatic
have the symptom.
Yeah.
People have small
Yeah.
hiatal hernias that all you
Sliding.
need to do is perhaps give them, a Nexium or something like that to maintain or to reduce the acid content, so that you prevent them from getting the erosive effect of acid on your esophagus. But then when you have this massive disruption and you get the stomach into the chest or the colon going into the chest, that's when you would need surgery. And it's called a hiatal hernia repair. And basically the concept is that you just reconstruct that that mechanism that basically would restore or prevent food from going up back into the chest. It's a well-oiled, thought of. We basically just reconstruct what God made, because it was already disrupted, and you tighten up the hiatus. You will bring everything down, and then you close the hiatus, and that would take suturing and repairing it, and basically prevent the stomach from going back into the chest. And that's the way that's repaired. But But again, we don't see a lot of it. But when we do see it, it's something that causes significant morbidity for patients, and really can impact your life. And so, again, if you're on PPIs for a long period of time and you're getting a lot, and you could sometimes some patients can even hear or feel like food is stuck, right? Mm-hmm. And that's one of the common symptoms too. That food gets stuck, it starts going down, and that's because your stomach is in the chest where it's not supposed to be.
And as a surgical oncologist, a cancer surgeon, do you see a large volume of patients in this population who have gastric stomach cancer?
Stomach cancer it's not that common in the Bahamas. We do see a few, but I would say it's one of the more rare cancers. We know the big three, right? The big three is prostate, breast, colon, hepatobiliary, pancreas is starting to get up there, and then gastric would follow. So it's not that common, but certainly. There's some obesity associated cancer risk, all right?
And alcohol.
And alcohol. We talk about smoked foods.
And obviously smoking itself.
And smoking itself. Cigars, all of that.
And cigarettes.
Yes. So there was a recent article published in JAMA where they said there was actually 12 obesity associated increased risk of cancers, right? Like endometrial. Esophageal,
and what is JAMA?
Gastric. That's a journal. It's one of our medical journals, it's called. Right?
A very well-respected
well-respected journal. So endometrial, esophageal, gastric, kidney cancers, colorectal definitely, liver, gallbladder, pancreas, prostate, postmenopausal breast cancer, as we always mention, ovarian and thyroid. And so you see all of these are related to, again, lifestyle, modifiable risk factors that we all often enjoy. And, 50% of endometrial and liver cancers are sometimes associated with, again, lifestyle factors. And so...
that's very useful information. And we're here on the Urologist Speaks trying to provide information. We're trying to save lives. We're trying to promote longevity and improve quality of life. But we're also trying to inspire the nation in any way possible. I had my sister and my brother on 2 weeks ago talking about positive things that they've accomplished, coming from a small 21 by 7 mile island and conquering the world, essentially. So we have here one of my sister's childhood friends and classmates in the form of Gemma Roll, and we have probably one of the greatest inspirations I've heard of in my lifetime in the form of Dr. Wesley Francis. Who came from 2nd Street, the Grove, and is probably is a household name, correct, Gemma Roll?
Yes.
A household name in all.
Dr. Wesley Francis.
Dr. Wesley Francis. When you say Dr. Wesley Francis, you immediately have untold respect. So obviously we've heard about your story. Let's just briefly go through it, because there are a lot of people in the Grove, a lot of people in the inner city who don't believe they can become Wesley Francis.
I think all your listeners know about my story.
Let's just briefly. Then we're going to go into detail of the life of Gemma Roll.
Let's talk about Gemma Roll's story. Is probably more interesting than my story, right? Everybody's heard my story already.
No, not everybody. Not everybody. But basically, your take-home message is that you can accomplish
resilience.
anything.
It's about resilience. Being focused. I think we got to be focused and we got to be resilient, and focus.
So there are those who you grew up with are dead or in jail.
Absolutely, yeah. But I always say a lot of people helped me along the way, right? And I think it's community. And every time I'm on the show, your father helped me a whole lot, right? I always say your father paid for my GCs. He probably don't remember that, but that was important. Someone had to help me. I couldn't afford it back then, and he did. He paid it for me. I often think, what would have happened if that teacher, which is your father, didn't do that for me? And so, and as we get where we are now, we got to pay it for. We have to, contribute and help other people to make it also.
And let's inspire a lot of young girls out there, Dr. Gemarole, who we need to look at you as the only female gastroenterologist.
Yeah, I'm the only female gastroenterologist
So
in the Commonwealth of the Bahamas.
How did you get to this point?
Listen, I'm a very competitive person. Let's go back to the days of being at St. Andrews, right? Shout out to my classmates, the class of at St. Andrews School. Listen, captain of the softball team, pitcher, the softball. I played softball, volleyball, field hockey, water polo, everything, you name it. I also did the first leg of the 4x1 in track, right? And I did field events. So I'm a very competitive person. So by the time I got to residency at SUNY Downstate in New York City, I said, what do I want to subspecialize in? I went in knowing that I wanted to
But even before that, how did you get into medicine?
Well, so when I was a child, I wanted to be a teacher. And then I developed this skin condition called eczema. And so I said I wanted to be a dermatologist. And then, dermatology is about being beautiful. But then dermatology also comes with a lot of funky skin lesions and whatnot. And so that threw me off. So I just said, okay, I'll just be a doctor, and wherever I land, I land. Wanted to go to Wake Forest because Maya Angelou was a professor there. I didn't get into Wake Forest, but I got into a small school in Worcester, Massachusetts, Clark University, not affiliated with Clark Atlanta. I went there because they gave me the most money. And I was pre-med, and I've had my advisor tell me, well, medical school is very expensive. How are you going to pay for it? And I said, my dad is going to pay for it. And he was taken aback by that. But really and truly, that's how it happened. So I started out with about 80 persons that looked like me pre-med, and I was the only one that finished pre-med. I took a year off, and I worked at the Memorial Sloan Kettering Cancer Center in Manhattan. And while there, I applied for medical schools. I got into one, went down, got an apartment. And on my way back to New York, because I was living with my dad, he was the ambassador at the time in New York City, they said that Howard University gave me a spot. Do I want to take it? And I said, of course. So went to Howard University. They gave me money too. I got a scholarship to medical school. And then I had a few Bahamians that were there. Tinubu, Olu's brother, was like a mentor for me at Howard. I did so well in my first 2 years that they hired me as a retention specialist, right? There were about a handful, maybe a dozen of my classmates that were about to fail. So we taught them during the summers. This is in medical school, taught them in the summers, and we retained all of our class. So I graduated with 95% of our class, right? So finished medical school, wanted to go to Galveston, Texas for residency. I was, we have that, what do you call it, the ranking system? Yeah. They didn't choose me. But I wanted to go to Galveston. And the year that I got into downstate was Hurricane Katrina. So everybody that was in Galveston had to relocate to other places. Ooh, so I would have had a delay in my training. And as a
so things happen for a reason.
H-1B visa student, I didn't have that cushion of a year that everybody was misplaced or displaced by Hurricane Katrina. So while in residency, trying to figure out what I'm going to do for fellowship, I realized that cardiology and gastroenterology are the most competitive. Why? Because we do procedures. Everybody wanted a GI spot. So you had the attendings, you had the chief residents, everybody wanted to do GI, but only, but so many few can get it. So they wanted to know why I wanted to be a gastroenterologist. And I told them I wanted to go home. So here it is, we have institutions that are federally funded. The more people that you have doing research and staying within the institution, the more money they get. But I wanted to go home. So who's giving me a fellowship spot? No. Every one of my electives was in GI. They called me the GI fellow. I was the only fellow that all of the attendings came from all of the hospitals, the Veterans Hospital, Mount Sinai, SUNY Downstate, Kings County. Everybody came and they threw me a party. Good luck. okay? For the girl that wants to go back home on the islands to be a GI fellow. So I got a spot right out of residency to do my GI fellowship. And I say my drive is my competitive spirit, right? If you go to school, I counted how much it costs each class for my parents to send me to college. Each class cost $200. I didn't miss a single class in college, not a single one. So, yeah, that's my story in a snapshot.
I think it's inspiring.
Yeah.
And I think you can inspire a lot of young people, and all we hear is negativity. Bahamian, our generation below us are not doing anything. There's so many bright sparks who are excelling.
And must I say, we have the most intelligent physicians on this side of the globe, okay? There's a lot of smart physicians right there at the Princess Margaret Hospital, other physicians that are starting out. Look them up. We're the best.
Well, sorry for the delay. We have a call coming in. Good evening. This is Urologist Speaks. Please go ahead.
Yes, good afternoon. Good evening to Dr. Pinto, to the lovely lady in there, and Dr. Wesley Curling Francis, right?
Curling Francis.
You can cut out the curling. It's just Wesley Francis, and it's Dr. Gemero, 52.
Dr. Curling.
Yeah.
Listen,
Francis.
at least I know who it is. But the thing is, I'm glad that she came back here, but she said something that jumped my mind. I did science up to A levels. I dropped to the COB, but I was always reading because of just general health. And I have books like probably as old as some of you guys. And so what I remember reading, right, and it dawned on me after she spoke about the acidity in the stomach, et cetera, et cetera. And so I remember reading literature decades ago that not all of the probiotics survive the stomach acid by the time they reach the intestines. And so I actually looked into a few that survived this. So I thought it would be mindful to just tell people that, because a lot of people learn probiotics, et cetera, et cetera. And so I also learned that the foods that you eat it with can determine how long it survives. I guess by like bacteria, they might have a capsid or whatever. But I've seen young people as young as 20 years old with ulcerative colitis. I don't know, maybe that's a precursor to colon cancer, et cetera, et cetera. But I'm so concerned about the level of cancer and the diet in that the origins of cancer. I'm reading a book now, right, that maybe all of you guys should read. It's called Vaccines, Mythology, and Reality, written by John Leake and Dr. Peter McCullough. And some of the things I've known, but I'm reading on it, and there's a lot of things that will maybe take some of the dogmatic ideas from doctors and they'll open up their minds. But I wanted to know if she saw the. By the way, I've had 2 inguinal hernias, and I know that the last one is botched because my body is telling me that. And so I do upholstery in which I work with my hands. So whilst I appreciate physicians, I think that surgeons sometimes make mistakes and they're not afraid to tell people, especially at that hospital, because I see a post on Facebook now with a gentleman who had a hernia, I think colon, the colectomy, what you call it, or rectomy or whatever, and so he has an ostomy bag, and he has 2 incisions that were not necessary, and he's having problems recovering, etc. And the family posted, and they're saying other physicians are reluctant to do it because of the liability, etc., etc. And I just would like you guys to comment on what I said, because Dr. Pinto.
Yes.
Could you do a show? Are you guys familiar with the simian virus, SV40 virus, and the biological weapons program that people call conspiracy theories, and the concept of using live viruses versus attenuated viruses back in those days that actually led to it's really ridiculous. I just you need to do a show on it, because the origins of AIDS and cancer and these viruses that came up under the biological weapons program that people don't want to talk about. It's frightening for me, because in order to move forward, the truth has to be said, and people are documenting these things. And so this is a link with the polio vaccines. And there's a lot of information in Dr. McCullough's book that is never being disclosed to the public, and there's a reason for that. I'll line up and listen. The truth must be told, man.
All right. Well, I think I'll start by defending Princess Margaret Hospital. We've spoken many times, Dr. Wesley Francis. There'll be 999 wonderful things done at Princess Margaret Hospital. And one thing that you need to, it might not even be wholly correct,
right?
Posted and reposted and everything else. What about the gang member was shot 17 times and probably would have died anywhere else in the world and happened to survive and are not.
Lived.
We don't hear anything about any of the positive things that are going on. Any closing remarks, Dr. Wesley Francis, in regards to colorectal cancer?
Listen, the evidence is showing that the numbers are going down, and that's very.
Screening is working.
Screening is working.
Hopefully,
and
a healthier lifestyle.
That's rewarding to hear.
Yes.
So I'm hoping that that's real, and we could continue to screen and prevent this dreaded disease.
And Dr. Gemarol, thank you for first
Thank
your
you for
inspirational
having me
story.
here.
And where can we find you if someone wants to reach out to you?
I am in the Oxford Medical Center. That is on 4th Terrace off Collins Avenue. My phone number is 425-0440.
And any last words on the topic, Dr. Gemarol?
Prevention is key. Colon cancer, the screening tool can prevent the cancer.
Okay, my last words, let's live better, let's live longer, and let's be good to each other. Let's stop the violence. Get out there and vote, and have a safe week, Bahamas. Good evening, this is Urologist Speaks with Dr. Greggory Pinto and Dr. Wesley Francis, and our guest, Dr. Gemarol, gastroenterologist. Bahamian female-only gastroenterologist, Dr. Gemarol. Good night.
Don't be ashamed. It's time to take control. Get some help from the urologist. You will find he'll help you solve your problems on 96.9. Yeah.